Do I have the mouse control? Hi, my name is Tariq. I'm calling from Chicago, and thank you for everyone who joined us in this webinar. The webinar is basically being arranged by the Education Committee of the NANS, which is a organization. It's a national organization which dedicated to spread of the neuromodulation therapy. The part of the core curriculum or the core mission of the Education Committee is to facilitate and help arrange through different avenues the education opportunities and training for the fellows and in residents and for the pain practitioner. It does that by different ways, as I said, by arranging workshops along with the publications. One of the new things which is being spearheaded by Dr. Mark Malinowski is that we are trying a series of webinars. And the idea is to highlight main educational themes and to discuss those things which should be known and should be spread. We are starting with the first webinar. It's understanding ultrasound, fluoroscopy, and radiation safety. We are joined by 3 great and really good, awesome speakers. In my mind, ultrasound, fluoroscopy are basically eyes and ears, mostly eyes. And if I have to say in one word, the main theme or what a purpose of a pain fellowship, interventional pain fellowship should be, that is basically how to learn fluoroscopy or ultrasound. And it's like learning how to catch a fish. It means you won't go hungry. It means you won't have complication. So today we are joined by Dr. David Provenzano, Dr. Gita Nagpal, and Dr. Dmitry Suzo. We're going to go in order. The first thing, it's going to be Dr. Dmitry Suzo, who's going to start with his Dr. Dmitry Suzo is going to start with his presentation on ultrasound. So I'm going to start. Dr. Dmitry Suzo is a director of clinical research at Pain Medicine Center at Western Reserve Hospital in Ontario. He is well published, holds leadership position at several national physician associations. He has special interest in head and neck pain, and he is really an outstanding expert in ultrasound guided pain procedures and even regional anesthesia. So the floor is yours, Dr. Suzo, all yours.
Thank you for inviting me, and thank you for a nice introduction. Let me get to the okay. We try the next slide. So it's working. So here my disclosures. Xray is a new name, is Xray Pain Medicine. There is no conflict of interest because this is a webinar, but Xray conducts hands-on workshops, and the one coming in June. Another one is American Interventional Headache Society. Another workshop coming in actually in 4 weeks there in Chicago. So the rest are not relevant to this program. Why it's important to learn ultrasound? It's not only because radiation safety, and David Provenzano going to be speaking about this. There is no radiation with ultrasound, but also I use practically all my peripheral neuromodulation programs with ultrasound. That allows to have a visualization of a nerve, get PNS closer to the nerve, but without damaging the nerve, contacting the nerve, without affecting the vessels around the nerve. So it's a good technique, and I think you should consider learning it. If you look at what needs to be learned about ultrasound, there are few important considerations. Image optimization, you need to learn your machine, image interpretation, and understanding of device operation. But needle visualization is probably the most important one. And I just thought about this Sleeping Beauty story when that small needle prick really changed the lives of many people. So this kind of brought me to the exploration of the topic. So the most two common errors with ultrasound are failure to see the needle during the advancement. That's one, and second is that ultrasound probe is moved without proper needle visualization. And we'll talk about factors of needle visibility, multiple factors. But before we go there, I'd like to thank Dr. Naruz, who is the one who taught me ultrasound. And I'm using his book. The chapter I wrote actually on needle visualization was his book on the ultrasound guided procedures. And of course, Dr. Provenzano, who is my mentor in ultrasound and many other things too. So thank you. We'll talk about factors related to the needle. And this is the size, the angle, the echogenicity, and the tip of a needle appearance. So we will see the examples there. This is, you see a difference between right and left image. The size of a needle, it does matter in terms of ultrasound. So you can use a larger needle, but then patients with chronic or persistent pain, they don't like large needles, so you have to kind of be adaptive there. The angle really matters. This is a little bit steeper angle. The same needle comes more kind of closer to parallel to the probe. You could see it better. There are different types of needles. That are needles that specifically designed for the ultrasound guided procedures, but most of the practitioners in my assessment using regular needles as soon as you're comfortable with techniques, but these needles are available maybe for special procedures. And you see a difference between a regular and echogenic needle. This one is much brighter. The needle tip is important to see. It gives you additional kind of information. You see, this is bevel down and this is bevel up. So you can localize the tip of a needle by just rotating the needle. Also sometimes bending a little bit the tip. Echogenic needle look different. It has some special markers, and it's really good for some kind of steep injections where you cannot just go parallel to the probe. So you may consider using some of this. And this is inside the vessel. You could clearly see it. The equipment is important, and we'll talk about various artifacts. This one here is reflection. You don't really see the needle well because of this artifact. And this one, the needle is actually here a little bit higher, but then you have reverberation where you have appearance of multiple needles. Most of the current contemporary ultrasound machines are compensating for these artifacts, and you're unlikely going to see it, but it's still possible. Another way to improve needle visualization with equipment is image reconstruction. This is normal ultrasound beam and reflected essentially in 45 degrees, but there is a technology which allows to kind of steer that reflection towards the probe, and that would allow better needle visualization. And most of the contemporary machines, they have it this technology incorporated, but in some machines you can turn it on and off. So here's the example. You go here, you don't really see the needle. You turn on this needle steering beam, and it comes and you see it. Doppler is important to use with ultrasound guided procedures. The frequency of the probe is important as well. You can see that there's a median nerve. You don't really see it well. With increased frequency, you could see it much better. And this is probably too high. Most of the machines are around 20 megahertz right now. But this type of, the increased frequency does not allow you to see deeper. So you have to choose depending on the intervention you're doing. This is 3D probe. This pretty bulky probe, but the image is very nice. This is a tip of a needle. You could see it very nicely, clearly. And this is the same with the 2D ultrasound. The same needle with 2D ultrasound, you barely see it. It's a phantom here. But you can see a difference. The 3D ultrasound is not routinely used in pain medicine, but if it's available, I would recommend to at least explore it. This is CT plus ultrasound. People try to combine different technologies together, and you can see some reconstruction of the image may be helpful, and this is in development. Needle GPS, it's essentially position of a needle. I'm not sure if you see it. It's a system which allows to project the beam, project the pathway of the needle. So needle is actually here and here, but then it kind of it gives you the pathway and shows where to go with the needle. It's not routinely available, but it is available. This is very important, maybe most important part when you align your probe with your needle. And the beam, the ultrasound beam, is not that big. It's not like a probe. Probe is probably ½ inch, but the beam itself is only about 1 millimeter. It's a credit card size, and that's why it's important to have good alignment of the probe. Otherwise, you'll not be able to see it well. There are two commonly used techniques. One is in plate, when you essentially put a needle parallel to the probe, and another one is out of plane technique. It depends on the procedure. It depends on the your confidence in the technique. Most of the time we use this type of technique, but you have to really learn how to see the needle. It's more difficult in this type of technique, but patients like it more because it's less irritation of the tissue. Get straight to the target rather than going through like significant kind of like tissue. So another technique is a bleed, and you can potentially learn this technique as well. It's kind of intermediate. It was described, but it's not commonly used. Initially, when you learn the ultrasound, it makes sense to use some guides. This is mechanical guide, and it will help you to align the needle. This is optical guide, and you can see that you can locate the tip of a needle and the needle very well with those additional tools, but they're not routinely used. Once you're familiar with the technology, it's not routinely used. This is the art of scanning, and A, it stands for alignment. That's what we just talked about. R stands for rotation, so it's clockwise and counterclockwise. So you gently, very gently move the probe. And another one is tilting. So you tilt the probe and you get the best image possible. And this is a commonly used technique. There are various abbreviations and additional options available, but these are most important tools. Another one is to learn how to hold the probe. I frequently see trainees just holding the probe and don't have their hands on the patient. It does not work really well in the practice, because if anyone distracts you, if you need to grab something, you off the target. So the way to handle this is to have two fingers, or maybe use some other techniques, but have your hand on the patient. In this case, it's two fingers on the patient, and this allows you to freely move the probe. Actually, works really well for many. Ergonomics is very important. If you position yourself the way that the screen is on the right, the patient is on the left, and then you go in between, it's pretty difficult to do, and also doesn't help with the procedure. So it makes sense to organize the environment the way you like it before the procedure, get the machine in front of you, or get the patient in front of you, and make sure you're not hurting your back or knees. So it's important to observe it. There are certain techniques, we call it enhancement tools, available to help needle visualization. They are listed here, and we'll talk briefly about them. It's called basic sonographic effect. As soon as you change the type of tissue you go through, so this is a vessel, you can see the needle better, essentially. And this needs to be considered when you do this. Here, the needle is here, you don't see it, but as soon as you put color Doppler and wiggle the needle, or vibrate a little bit, or put guide wire on, or do some priming, you'll see it better. But patients don't like wiggling, especially chronic pain patients. When you move a needle around there, they don't like it. So be careful with this type of technique. Here is the needle, and you don't see it, and I don't see it either. So one of the common ways to improve needle visualization is to do hydrolocalization. So essentially, you inject a little bit of local anesthetic or normal saline, depending on what and how you're doing, but you can see the needle tip immediately after that. And this is because of that basic sonographic effect when you change the environment around the needle. Microbubbles rarely used, but available. So you essentially create some kind of area of bubbles. Then you don't really see what happened next after that. So this is not routinely used technique, but it's available when you use microbubbles as a contrast. Neurostimulation can be used as a part of the technique. We don't use it routinely, but I can imagine some of the cases would be considered. And training, there are ways to learn how to navigate the needle with ultrasound. There are certain teaching technologies when you have cross sections along with your actual ultrasound image and the database you can compare. There are simple models like this is tofu, this is water, and you can practice the alignment. These are relatively inexpensive models this one is more advanced, but this is you can see this is cervical spine in the water, and you can practice the cervical nerve root blocks here. This is more advanced system. We actually created it to learn how to do selective nerve root blocks with ultrasound, and it's a high fidelity simulation. It works actually really well if you can see it. There is it's difficult to be sure which one is a real picture. In this case is this one or this side here and here. This is the phantom. It's a high fidelity simulation here. So you can see nerve is here, anterior tubercle, posterior tubercle, and you can simulate the flow. Here is a confirmation with Xray, and this is phantom as well. This is for the training purposes. The machines are very different, so it will be difficult to learn. We call it knobology on one machine, but usually the representatives, they will explain how it works. The key is to learn how to regulate the depth, and then the focus. It will help you to see things better on the different depths there. Here they regulate the frequency of the probe, but a lot of the time it's done differently. So this is it on the needle visualization and some other techniques. And thank you. So this upcoming hands-on workshop with Astro Pain Medicine International Headache Society. I don't think I create a conflict here because we're doing webinar, not hands-on program. Thank you.
Thank you, Dmitry. That was so good. I feel like we all learn when we listen to you, when we hear you talking. So we'll keep the question till the end. I'm going to introduce Dr. Gita Nagpal. She's our next speaker. She's the program director of Pain Fellowship at Northwestern University in Chicago. And she's also the director of Boston Pain Society and the president of the Midwest Pain Society. And when she's free, she reads historical fictions and chauffeurs children around in the city. But today she's going to be teaching us about how to use a fluoroscopy or how to work with them. Thank you. Thank you, Dr. Nagpal, and you can start. All yours.
Thank you. And thank you for inviting me to do this because it got me out of my Wednesday night chauffeuring duties. So I'm going to talk a little bit about understanding fluoroscopy. I think understanding fluoroscopy is a relatively broad topic, and this was not a canned lecture for me. So I did my best to piece things together. I know everyone's had a long day and it's almost bedtime, so I wanted to keep it interesting, short, educational, and hopefully not putting you to sleep. Let's see if I have the control. I should have control there. I'm trying not to be impatient. It doesn't look like my slides are moving. Does someone else mind going to my next slide if they're not moving?
Check. I think maybe Lily has the control. Oh.
There's one. I hope it wasn't that slow because now I've pushed it 7 times. But my only disclosure here is that I'm really not a nuclear scientist or a radiation physicist. There are people that are very specialized in this. My mom's actually a nuclear engineer, so she'd probably be very disappointed in my talk today because I'm not as smart as her, but I will do my best with what knowledge I remember from college and what I use on a day-to-day basis. Next slide. So what are some key points? X-rays are produced de novo as needed. There's actually no radioactive substance that's used in them. We produce the radioactive or the radioactive energy. X-rays travel in straight lines and are attenuated according to the density of body tissues. X-rays are in our atmosphere. We're being X-rayed at all times, and they are potentially hazardous. I'm not going to get into the hazards and dangers so much because that'll be our next lecture. So I wanted to go through an incredibly brief history because I think that it's important to understand where our technology came from. And it's also really fascinating. So a German physicist, Wilhelm Röntgen, which that name will come up again, discovers X-rays in 1895 and takes his first image, and it may be his wife's hand, and she was mortified of the look of her hand, but he won the Nobel Prize in Physics for this. Then Thomas Edison invents the first fluoroscope. And why do I have Madame Marie Curie on here in 1887, who discovers radium? Because again, we don't have radium in our X-ray machines, but I'll get into why she's important as well. In 1899, compensation was awarded for the first medical malpractice suit involving an X-ray injury. That's important because that still happens today. Hopefully not in our pain practices because we are not using usually that much X-ray for one procedure, but I have seen it in my clinic with patients that have had X-ray injury from vascular or cardiology cases that were difficult or went a little longer. 1929, the creation of the National Council on Radiation Protection and Measurement. And then we started using fluoroscopy in the late 80s for interventional procedures. And in 1994, the FDA issued a health advisory because of patient injuries from excessive use of fluoroscopy. So we have to understand the power behind fluoroscopy. We have to understand how to interpret the fluoroscopy, but we need to keep our patients safe as well as ourselves. So as I said, that on the left there is the first X-ray that won the Nobel Prize, a lovely hand and a lovely ring. And this other little gem of a buggy is from World War I, and that's where Madame Curie comes in, even though she won her prizes for the discovery of radon. She was actually really, really prominent in this portable fluoroscopy unit. She came up with it to help the French soldiers in World War I, and basically put together these little units that she could take out to the field with her team. Many of you know that she actually died from an aplastic anemia in her 60s, and a lot of that is thought to be due to her discovery working with nuclear reactive substances, but she actually believed it was from exposure during this time, because she was doing these very probably high penetration, high intensity X-rays through World War I. So why are we here? A basic knowledge of X-ray physics is complementary to the knowledge of X-ray interpretation and important for provider and patient safety. Radiation is an energy radiated or transmitted as rays, waves, or forms of particles. I'm going to show you those nice graphs that you've seen in probably high school and college. And then X-rays are just one portion of the spectrum of electromagnetic radiation. So this is compliments of NASA. And again, this is probably something we've all seen throughout our studies, which is that the rays from gamma rays all the way to radio waves. We probably all listen to some radio waves on the way to and from work. We love microwaves to warm up our food. Infrared, I wish I could see at night, but that's used to be able to see the heat off of objects. And then our visible rays that help us live, ultraviolet rays coming from the sun that are making us, darker skinned or giving us skin cancer. That ultraviolet to radio are non-ionizing rays, whereas X-ray and gamma rays are ionizing rays, okay? So the shorter wavelength, higher frequency, higher energy are radioactive, all right? So let's talk a little bit about the physics of X-rays. It'll be petite. As X-rays pass through matter, they impart enough energy to dislodge electrons, and that's how we are creating our images. So ionizing radiation can lead to harmful biologic effects. We'll talk a little bit about measurement of that. In fluoroscopy, it's the X-rays that penetrate the body without effect that actually emerge the image intensifier, which I'll show you a picture of. We can convert that to visible light on our monitors, and back in the old days, even transfer to film. I haven't thankfully had a patient come in with film for me. I don't even think our new clinic has the film viewers anymore. So the image is based on X-ray penetrability. All right, so X-rays are a form of ionizing radiation, just like gamma rays, that can be created in the fluoroscope and harnessed for medical imaging. They're produced in the tube of the fluoroscope. So you have a cathode that's expelling electrons from a circuit, and it focuses them on a spot on a metal anode. And it's not the entire anode, which is made of tungsten metal. It's a very kind of small area of the anode that then hits, and I'll move on here, creates an X-ray. The electrons themselves are produced and expelled by heat and heating filaments. And then when that heat and electron hits the anode, we get our X-ray. So we've probably all heard of REM. So REM is a unit of radiation dosage applied to humans. And that's derived, so again, when we think back of our history of who got the Nobel Prize for inventing X-ray, it was Roentgen. And so we have a Roentgen equivalent man, a REM or REM, okay? What's the biological impact of radiation and how do we decide that? So X-rays and gamma rays are less damaging to tissue than there's a lot of ionizing radioactive substances that aren't necessarily on our spectrum of wave panels, such as alpha particles. And so we have a conversion factor that's used to translate the rad or gray into other units such as REMS or sieverts. I'm going to show you a little bit more of those definitions, and that's how to express biologic impact. So again, Madame Curie comes up with our Curies versus, you can see them all. So we have the raw physical units describing radiation emitted by a radioactive material. The rad and the gray is the measurement designed to reflect the different amounts of radiation energy absorbed by a mass or material. And then what we see more, the REM, we're measuring the relative biological damage in the human body, which depends on the type of radiation. So I just pulled this from the US Nuclear Regulatory Commission, more just because that's their definition of a REM, which I think I can understand the first paragraph or first line of it, which is one of the standard units to measure the dose equivalent or effective dose, which combines the amount of energy along with the medical effects of the given type of radiation. So X-ray exposure is everywhere, as I said. Per the US Nuclear Regulatory Commission, the average American absorbs 620 millirem per year of X-ray. Half of this dose does come from background radiation. They call it raining from outer space. So higher levels or higher elevations, cities like Park City or Boulder will have more cosmic rays and less atmospheric atmosphere to actually deflect the rays. So when my husband wants us to move to Park City, I say there's two things that are a problem. There's not enough oxygen, there's too many X-rays. Flying in a plane is going to expose you to X-rays as well. You're going to get a higher dose in a plane as compared to traveling by car. Plane is typically faster depending on your delays. So to give a kind of comparison of what is a plane to an X-ray, New York to LAX exposes a person to 2 to 5 millirem. So a round trip New York to LA is going to be close to equivalent to a chest X-ray. And now a full body CT, which I'm sure most people aren't getting full body CTs because that's a lot to CT, I guess, if they really don't know where an infection is maybe, but that's 1,000 millirem, so 1 rem. Humans exposed, maybe you guys have seen or read about Chernobyl. There was a nice little documentary on that. Humans exposed to 500 rem at once will likely die without some sort of treatment. There's another really good book that my kids actually read. It's called, Radon Girls, I think, or oh no, I don't even know why I brought it up. Now I don't remember, but it's about workplace and the paints that women use, or they used to paint the dials of clocks, and a lot of them got very, very ill and died from the amount of radiation they were exposed to. So this is a picture of an X-ray machine. Let's see here, I don't know if you can see my mouse or not, but right here is the actual X-ray source or the tube, and then you have the image intensifier that creates the image that's displayed on the actual monitor. Obviously a table of the patient, and I'll go into the control panel, I think, next. Let's see here. This is my little picture. It's a very crooked. I took of a control panel in our clinic. As Demetria said, the knobology can change. So I initially walked into one of our we have 3 different X-ray rooms, and we happened to have a new machine, and I was about to take a picture, and I was like, you know what, these buttons are completely in different areas and have different names or anything on them I'm not used to. I'm gonna go to the older machine. So we'll go through some of these in a little bit more detail, but you have your save image workstation, moving it from one monitor to the other. These orientation buttons always get me when you wanna flip, when you have a patient supine with their head towards one wall versus flipping them or prone, sorry, and then flipping them supine, and now their heads towards a different wall in order to reverse the image so that you can see the knee as you are perceiving it. You have the ability to do that, or if you're doing an LP in the lateral decubitus and your needle is going upward on the patient's body, but it looks like it's going downward on X-ray, you can flip the image to make that easier for your brain to perceive and your fingers to do the right thing. So in this middle section, this purple, this is collimation. We'll talk about that a little bit. And then we're gonna also talk about pulse, low dose, and some of the ABC controls. So this is a picture, that little heart is just to cover my patient's name, but this is a picture that my X-ray tech took for me just yesterday, just to show the difference of a low dose image versus a standard continuous image. And you can see on the left, it's a nice clear image of a lateral view of a L5S1 epidural steroid injection, whereas you get a good view here. You can see everything you need to see on the right side, but you can see it's much more grainy. So less intensity, a lower dose, which can be appropriate, but maybe by your end run, you want to have a better image. So we'll talk about that a little bit more. So let's talk about dose and frame rates. When we talk about pulsed and continuous X-ray, a lot of us are taking a shot, but we're also doing live runs. And this took me a little bit to kind of figure out the understanding of what it meant of this pulsed and continuous. And I wanted to kind of back it up to what we do a lot, probably when we get home and you're watching Netflix, or maybe you go to a movie pre-COVID, where everything is frames per second, right? So our eyes perceive things, and the way to make things smooth is to have a certain number of frames per second. So Hollywood is shot in 24 frames per second. If it's much less than that, our eyes can kind of see the choppiness. So if you look at really old movies, they might be a little bit more, and that might be less frames per second. TVs at 30 frames per second, sometimes there's interlacing as well. There can be interlacing with X-ray, but we're not going to talk about that. So what is continuous versus pulsed? Well, a continuous fluoroscopy is about 30 frames per second, whereas pulsed can range. It can range around 7.5 hours. According to my X-ray techs, our pulse on ours is set to be 8 frames per second. It can be 8, 10, 15, something like that. What I've read is that it's typically around 15 frames per second. It's based upon how our eyes, our human eyes, actually acquire the image, because we need to be able to acquire it in a way that we're not distracted by seeing different frames. But what it does is that it reduces your dose of radiation when you have less frames per second than more. Just less is more, I guess, in that sense. So if for pulse fluoroscopy, the dose rate is determined by the dose per frame and the acquisition frame rate, okay? So when looking at lumbar punctures, they did lumbar punctures using pulse with 15 frames, 10 frames, and 7.5 frames per second as compared to the continuous. And there was a dose savings of 22% versus 38% versus 49%. So when you're using a pulse mode as compared to a continuous mode for a procedure, you could be saving about 50% dose of your X-rays to your patient, to yourself, and as well to your personnel. I hope that made sense. It's always strange doing these talks because I don't see anyone's faces. I can't tell if what I'm saying is making sense. So we also want to optimize the position of the X-ray tube. The tube should be far from the table, but also you don't want to see unnecessary structures. So to minimize radiation to the patient, the tube actually if the tube is close, you have a small area exposed, but a high dose of radiation. If the tube is further away, there might be a larger exposed area, but the dose is much less. And then we're going to talk about collimation also. So bottom line is that you usually want the X-ray tube further away from the table. If anyone's heard of object to image distance, I think these are just nice pictures that I stole off the internet to give an idea of what does that mean. Object to image distance, it basically is how the shadow of what you're creating from your X-ray is going to look. So if you see on the left, you have a patient that is prone, maybe prone or standing against, their chest is against the X-ray film. So the heart, if that's what you're X-raying, is closer to the film. When you look at the source and you see the beam, you're going to have maybe a 13-centimeter shadow. If you flip that patient around and now that X-ray film is on their back, you are going to get a much larger shadow. So that object to image distance is going to affect the size of what you see on your monitor. We'll talk about collimation, which was the circle but purple buttons on our little control panel. It's a built-in mechanism that allows the emitted beam of X-rays to reduce in size and change shape. For the most part, it's linear or circular collimation. This is helpful because automatic settings optimize the image quality across an entire field of exposure. So if you have I'm going to show a picture, but if you have a small thing that you're X-raying and then you have all this air outside of it, it doesn't optimize the quality of your contrast dye spread as well, and that's when collimation can come into play. It's difficult to also visualize things in radio dense and radio opaque images in the same picture. And so let's see here, I have a picture here of some collimation on the left. We have a linear collimation in the cervical spine, and this is a lateral view with some, I guess, medial branch blocks or RFA. And you can see the neck is pretty skinny. You don't need the whole picture, so you can shrink it down to really optimize the imaging of your actual spinal structures. On the right here, we have a knee injection with lovely contrast dye, but that could have been collimated down so that you're not capturing all the surrounding area beside the knee, and you can get a better image quality and then have less X-ray as well. All right, magnification. So fluoroscopy units allow us to magnify, and it's fabulous when you're like, oh, I don't know if I can really see that inner space for the cervical spine, and you can collimate and then magnify the image by electronically magnifying that area of interest. It does allow for better visualization of a small area, but it can lead to increased radiation exposure. So you really want to think about that and weigh that appropriately. So to minimize the dose when you mag, you should also collimate so that you're seeing that really direct area of interest with all the appropriate structures that you need, and then magnified. All right, so now optimizing image quality. The lovely part about optimizing image quality is that our machines mostly do this for us. So we have automated brightness control, or ABC, which adjusts the MA and KVP for optimal brightness. So KVPs are penetration, MA is our intensity. So MA is a milliampere, and that increasing the milliampere produces more X-rays. The more X-rays to strike the image intensifier, the darker the image. And then you can also lengthen the exposure time to increase the number of X-rays as well. So then when you increase the voltage, which is the KVP aspect, this results in X-ray emission at high energy level, so that penetration. In general, our ABC modes are having a high KVP and a low MA to optimize our image quality as well as exposure. Really, I'm not going to go into much more than that because our machines they're smart enough to do that for us. That's why you don't see other than maybe in the thoracic spine, et cetera, that you may need to play with the image quality a little bit. I quickly just threw this in here last night, which is just digital subtraction angiography. Another thing that we can do with fluoroscopy for patient safety. It's certainly a high dose radiation technique, but this way with digital subtraction angiography, you get to remove all non-moving parts to really see a live run of contrast and see if you have pure epidural spread versus having some spread in vasculature. It can feel very straightforward and a slam dunk, except when patients are jiggling around because they're having a paresthesia while you inject. They have bowel gases moving, which unfortunately you can't say hold your bowels. You could say hold your breath, but if the bowels are moving, you may not be able to still get a great image. So it's not foolproof, but it's another safety measure for our patients when we're doing these injections. I just was going to end with some real basics. And I assume a lot of people know this, but I didn't really know what I was getting into when I accepted doing this lecture. So I think I just wanted to go into some true anterior, posterior, true laterals and how that's important. And you can see that the images on the A and B images are a little different. Well, we don't always have a true anterior posterior when we're doing maybe an intralaminar epidural steroid injection, because what we're doing is really optimizing our intralaminar space. But maybe for a kyphoplasty or RFAs, you want to line up your end plates and have those true anterior posteriors and make sure. So you can see on A, you have a more lined up end plate versus B, you do not. And then true laterals. True laterals are something that I talk to my fellows about all the time. I think it's really important, especially I do my cervical medial branch blocks in the lateral decubitus position. And if you do not have a true lateral, you don't know if you're going towards the right or the left facet joint or the trapezoid. So on section A here, you can see that there's overlap. Hopefully you can see it, that there's a one-sided joint and then another sided joint, and you can see that there's a little bit of a separation versus the other side being a little bit more clear. So making sure you have a true lateral is important. In fact, can't remember if it was today or yesterday, it looked like we were a little deep on an RFA probe, and I said, you know what, I don't think this is a true lateral. So we got a true lateral, and it was still a little too deep. But at least we got that true lateral to confirm that we needed to reposition our needle. The true lateral, I find laterals when we're doing thoracic spine, thoracic epidural, sometimes I think it's easier the old-fashioned way when we were anesthesia residents and you're just doing it by feel, because the ribs can throw you off, as well as what we're talking about with the different densities, because you've got the air from the lungs as well as the spine, but you also want to make sure you understand that true lateral in the thoracic spine, because those ribs can throw you off and you may think you're deeper or more shallow than you are. And then I was just going to end with my irradiated babies. I think it's a little plug also for women out there. I think that not enough of our female residents are going into pain medicine. I don't know if some of that is because of childbearing years being during residency and fellowship and the concern for radiation, but this is my N of 2, and so far so good. That's it.
Oh, thank you, Dr. Nagpal. I think when you said you couldn't tell who was, if you are making sense, it was making sense. We were listening. And in fact, I think when the radiation came, I remember in a news article, they were using radiation to the face to treat acne, and people were getting skin cancer. So they were using that to begin.
My mom actually said that she had, when she was a kid, they would go and take x-rays of her feet in India to do the shoe size. And I think they did that here too. So x-rays were used for a lot of different things like that.
Thanks. We're going to save the question for the end. And now we have Dr. Provenzano. He doesn't need an introduction, but I still have to say something, so I'm going to say it anyway. So he serves as an external member of Robert Morris University IRB. He's currently president-elect of ASRA Pain Medicine. He's a principal investigator on multiple research studies and published numerous articles. And he has lectured at many national and international places. He has special interest in radiation safety and even infection control, but today he's going to talk about radiation. So thank you, Dr. Provenzano, for joining us. We are honored. Thank you.
Thank you so much. Thank you for having me. So again, I'm Dave Provenzano from Pittsburgh, Pennsylvania, and it's a real joy to be here. That was the last 2 talks were excellent. There'll be a little bit of overlap with the last talk, but I'll try to add additional information. I think we can continue to learn on these topics because they're so important. These are my conflicts. They do not have anything to do with radiation safety. We do have funded research in our pain program on neuromodulation, and I do also consult in that space. So I will start off, you heard the last lecture, which was excellent on some of the topics you need to think about. I got interested in this because when I was a fellow at Dartmouth in 2006, I can still remember this. I love my fellowship. It was excellent. I got great training, but I have to say on fluoroscopy, the training could have been better. And it's nothing picking on Dartmouth. It was just the reality. In 2006, I got probably less than an hour of training, and then we controlled the machine as fellows. And what happened was I actually, in my fellowship, I got an ALARA level 1 warning, and I got a piece of mail in my mailbox, and it said ALARA level 1, and I had no idea what it meant. I just came home and showed my wife, who's also an anesthesiologist, and I started to look into it, and I realized like I had little to no understanding of radiation safety. And we were using a lot of live fluoroscopies on just simple bread and butter injections like interlaminar epidurals. So I started teaching about radiation safety. I taught at the ASA, and then finally 2 years ago, we published this large survey on radiation safety and knowledge, an international survey of 708 international pain physicians. And it was a 49-question survey, and I hope some of the people on this webinar actually participated in it, but I'm very grateful for all the societies, NANS, INS, AAPM, ESRA, ASRA, the Association of Pain Program Directors, for helping us distribute this. We had a great response rate. It's actually the largest survey ever done on radiation safety. And so the survey looked at 49 key questions, and we looked at practices and knowledge. We actually put our survey through extensive testing. I'd like to thank Sam Florentino, who was one of our research interns, who was very fundamental in getting this done. We pilot tested the survey, then we released it. We had over 700 physicians respond. And it's really interesting. 93% were highly concerned with radiation, so I was happy to see that. But the education was really no different than when I got in my fellowship. Only 63% received education and training, and only 30% got greater than 2 hours. And 65% of institutions did not require an annual education, and only 37% had an examination requirement. And actually, the places that had the worst education were hospital-based. And so you can see here in table 2. So what can I summarize this about? We use fluoroscopy. We just 2 great lectures on fluoroscopy and ultrasound guidance. We get so little training on this technique, and it has health hazards. There's no doubt. There's health hazards to you, to your patients, and also to the other people that help you in the room. The Xray tech, the nurses, you have to protect them. So if you look at the International Commission for Radiological Protection, this testing and this education that was gotten by a majority of participants in this survey would not meet the requirement. They basically wanted a day of training. They wanted you to be facilitated by a facilitator watching what you do, and they wanted you to have an exam. And most places are not doing this. And so what we did is we had questions on compliance for radiation safety practices. These were based on best practices for the International Commission for Radiological Protection, the National Council on Radiological Protection. And these are simple things like radiation protection equipment. What type of minimum lead equivalent should you have? 0.5 millimeters. Should you use safety glasses? Should you use lead gloves? We heard a little bit about badge and dose monitoring. You should have a minimum evaluation of radiation bad monthly. You should check your lead for cracks on a yearly basis. Where should you store your badge? Where should you place your badge? Are you recording fluoroscopy times? Are you recording the cumulative dose as part of your operative procedure? And are you collimating, which we heard just about before? And what you can see is that the compliance rate, which is in the second column, was very, very poor. You can see that only 4% used radiation headgear. Well, I will tell you, I'll show you a slide coming up here, that we are no doubt at higher risk for glioblastomas. If you look at the cardiology literature, the cardiologists have a higher risk of glioblastoma on the left side of their brain, which is outside of the proportion of the general population, and that's because the left side of your brain is close to the image intensifier. Most people are not utilizing lead gloves. We need to protect our hands. It's also important to remember that lead gloves are not meant for primary beam radiation. They are meant for scatter radiation. You're not supposed to put your hand under the beam. We heard a little bit about automatic brightness control in the last talk. If you take a lead-lined glove and you put it under the beam and you're using the ABC control, the machine's actually going to pump out more radiation. So these are, again, just for scatter. And most people didn't use glasses. Why is this important? We know that individuals that use fluoroscopy have 3 times the rate of cataract development compared to individuals that do not use fluoroscopy. So you need to protect your eyes. And what you can see here is only 13% of these compliant measures that were based on best practices that should be well practiced by all physicians, only 13% were associated with greater than 80% of physicians selecting the correct answer. So very poor. Most people didn't even understand which type of lead you should be having to protect yourself from radiation. 0.5 millimeters. Doesn't mean it has to be lead, but it should be some equivalent that has that degree of protection. There's a lot of biomaterials now that are used instead of lead. Then we did knowledge of radiation principles, ALARA. We should all know about this, the inverse square law. I'll talk about this. Radiation effects, stochastic, non-stochastic effects, the biological effects of radiation. We saw some great pictures just recently on how you should place the X-ray tube, C-arm orientation, radiation units. And what you can see here, 0 out of 10 questions were answered by correctly by greater than or equal to 80% of physicians. So people did very poorly on this. Now, the good news was when we looked at the amount of education that patients, that the physicians self-reported, this was self-reported education that they had gotten, there was no doubt that people that had education were much more compliant with evidence-based practices. So education does make a difference. But the problem is that people overestimate their ability. It's called the Dunning-Kruger effect. So just because you have a little bit of education, you think you know a lot. And most people didn't. And you see this here. This is when you know nothing, but you're extremely confident. And basically that's what we saw. People had a little bit of education. They thought they knew a lot, and they did not know a lot. They didn't answer the questions correctly. This is not to pick on any of the people that answered the survey. I'm very happy that people were honest. It just shows that in our field, we need to pick up the education on this topic. And actually, the other part that I'm not showing here is that part of the survey looked at fellows' education. And by the time the survey went out, most fellows would have been between 9 and 12 months of their fellowship. So they're almost done. And very few of them had any education on radiation safety, or it was extremely limited. So what we concluded, and this is why we had these talks tonight, is that there's significant deficiencies in the implementation of evidence-based practices. There's significant gaps in radiation knowledge. The levels are low. Most people get less than 2 hours, if any, education. Problem was people are overestimating their knowledge, and we need to define educational plans with continuous learning strategies. And we all need to go back and look at the International Commission on Radiological Protection guidelines, which strongly recommend that you have at least a day of education, that you have someone watching you do the procedures, and you take an exam. So in conclusion, this was the conclusion of our paper. Fluoroscopy will continue to be the cornerstone of image guidance for interventional pain procedures in the foreseeable future. The detailed information provided in this survey can be used to tailor education. Based on the survey results presented here, failure to implement educational change would be unacceptable. I would ask anyone that's involved in fellow education, this needs to be heightened because the fellows did extremely poor in the test results. So I'm going to talk to you about some things that you can do to make your life much safer. And I'm talking to you about the biological effects, the fluoroscopy unit, which will be a little bit of a review. And remember, you designate how that machine's being used. You need to protect yourself, the patient, and the personnel in the room. Why do we care? Because the lifetime radiogenic risks depends on a few things. Your annual operative load. So if you figure that you start practicing interventional pain in your 30s, you can have about 30 years of radiation exposure. That's a lot of radiation exposure. We know that individuals that don't have good radiological protection are at much higher risk of cancers. This was an Italian study that looked at orthopedic surgeons. They were doing like 50 hip cases, 50 spine cases, and 50 kyphoplasties, so not that many. And the lifetime excess risk of fatal cancer was about 1%. There was also another study looking at poor radiation safety practice. And individuals that have poor radiation safety practices were 5 times more likely to develop cancer. Furthermore, in interventional cardiology literature, there's an association between radiation exposure and glioblastomas on the side of the brain that is closest to the image intensifier. You can see this here. This was published in 2013. This is the country that the individuals were from. This was the year that they were diagnosed. This is the age at which they were diagnosed. You see that most people were diagnosed in their 60s, and they had about 20 years of radiation exposure. The tumor type was glioblastoma, was on the left side of their brain, which is closest to the image intensifier. As we all know, when you get a glioblastoma, the outlook for prognosis is terrible. And you can see the latency. This is the thing, like we use this invisible thing called radiation. We don't see it. It's not going to affect us tomorrow, so we don't really care. But 20 years from now, using all this radiation, it's a problem for us. What they concluded was, in conclusion, these results raise additional concerns regarding brain cancer developing in physicians performing interventional procedures. Given that the brain is relatively unprotected and the left side of the head is known to be more exposed to radiation than the right, these findings of disproportionate reports of left-sided tumors suggest the possibility of a causal relationship to occupational radiation exposure. We need to take measures to prevent this. There's 2 types of radiation effects. There's stochastic and non-stochastic. Stochastic are non-threshold, randomly occurring, and what happens is that the probability increases with higher doses. This is such things as cancer and genetic changes. So what I mean by this is, I can't tell you that if you stay below this dose, you will not get cancer from radiation. And that's why they no longer have minimal permissible doses. We no longer use that terminology. It used to be called MPDs. That if you stay below these doses, you're always safe. We now know that's not true because the stochastic effect, such as cancer, is non-threshold. It's randomly occurring. All I can tell you is that the more radiation that you are exposed to, the probability is higher. But I can't give you a level. And you could just have a bad day. Your cell gets exposed, gets a genetic defect, you start the whole mutation process, and cancer begins. Then there's non-stochastic effects. This is things such as cataracts or hair loss. Now, these you need a threshold dose. You need to exceed the threshold dose to get the effect. Now, we should never exceed the acute limits for this, as long as we take appropriate measures. We're not going to get a cataract exposure from one case. We should never exceed this as long as we take the appropriate measures. But what happens in our job is we get something called dose fractionation. That is, we get delivered radiation over multiple sessions. And what happens is a significant previous exposure decreases your single dose threshold, and the effect is less likely to be seen at a much earlier rate. Now, when you look at all the effects between irradiation and the sign, a non-stochastic effect can take hours to months. And again, if it's really dose fractionization, you may not get cataracts for years, but it is additive. So if you get all this additive exposure, it is additive for a non-stochastic effect. Now, for a stochastic effect, such as cancer, it can take years or decades. And you saw that in the glioblastoma slide. These patients had about 20 years of exposure, then they got the glios. Now, we saw some great slides about airplane flying and travel, which really, we do get background radiation exposure. I'm going to put this into like, we don't do much discography now, but in the old days when we used to do discography, let's take what a discography may have been. You have one chest X-ray. She equals anywhere between 10 to 15 millirems. Now, when you step on the pedal for your machine, depending on how it's set, it puts out anywhere between 2 to 10 rads per minute. If you step on the continuous fluoroscopy pedal, and again, it depends on whether you press the boost button also. But even if you don't press the boost button, it's anywhere between 2 to 10 rads per minute. If you did a 1-level discography, and it took you 60 seconds of live fluoroscopy, 1 minute times 2 rads equals 2,000 millirems. That is equivalent to 133 chest x-rays. And if you look at background equivalent radiation time, that's equal to about 1,330 days or 3.6 years. So you expose that patient to basically over 100 chest x-rays and over three years of background radiation. So it was not to be taken lightly. So say you're doing a spinal cord stimulator trial and you're struggling to get the leads in and you spend over a minute. Same thing can happen. You're stepping on the continuous fluoroscopy button. You could be putting out as much as 2 rads per minute. You could be exposing those patients to a lot of radiation. And I will tell you, the International Commission of Radiological Protection does have cases of skin burns from spinal cord stimulator trials. We should not be getting exposed to primary beam radiation. It should all be scatter. But we have to protect ourselves from scatter. There's small angle scatter, which degrades our image. But remember, all energy is absorbed by the patient. Now, what does scatter depend on? Well, we heard some discussion on KVP and MA, your machine settings. Orientation of the beam has a big role in how the scatter pattern is. And if the patient's heavy, it's another penalty for a patient being heavy. You get more scatter. So the simplest thing you can do is reduce the time of exposure. We heard things about pulse fluoroscopy. For example, when I do my stimulator trials, I never use continuous fluoroscopy. It's all pulsed. I don't need to be seeing exactly. I need to have a decent picture, but it doesn't have to be perfect. Now, when you're doing something like a spinal cord stimulator trial, it is hard to increase your distance from the source of radiation. But when you do your bread and butter procedures like medial branch blocks, epidurals, you can have your radiation technologist set the image up. You can use a laser pointer. You can stand behind a shield, and you should be nowhere near the beam. Because remember, it's increased distance from the radiation source. Exposure is inversely proportional to the distance squared. So if you double your distance away from the beam, you decrease your exposure by a factor of 4. So just taking 2 feet steps back, you've reduced your exposure substantially. Shielding is also critical. But even with shielding, you're still going to get some exposure through 0.5 millimeter lead, and so you still need to protect yourself. We heard about the X-ray fluoroscopy unit. I will tell you, as was pointed out previously, this is the image intensifier. This is the X-ray tube source. This should always be under the patient. You want to collimate as much as possible. And also you should be using the automatic brightness control, which was discussed before. That helps us use lower radiation. Also, when I do transforaminals, I use digital subtraction, but I stand behind a shielded window because digital subtraction puts out substantially more radiation to you and to the patient. So when you use it, you should comb down. You should keep the image intensifier as close to the patient as possible. Keep the X-ray tube as far away from the patient as possible. And you should protect yourself. I don't put my hand anywhere near the beam. I have a long extension tube. I have X-ray gloves on to protect myself. When you use the machine, as was discussed, the image intensifier should be as close to the patient as possible. The X-ray tube should be as far away as possible. This is optimal. These small steps substantially lower your exposure. Look at this, for example. Here, when you look at the figure on the left, the II is very close. The X-ray tube is far away. Now look at this. C. The II is far away. The X-ray tube is very close. That's not optimal. Look at the difference in exposure. The difference between A and C, the skin entrance exposure is over 260% higher. By just making small changes, you lower the exposure substantially. Isodose curves. So you're doing a procedure like the mild. You're using the contralateral oblique. So it's pointed, the II is over here, your head's over here. Look at all the exposure that gets to your head. This is why the contralateral oblique is a horrible image when it comes to radiation exposure. And paradoxically of what you would think, when the image intensifier is far away from you, you actually get more exposure to your head. When you're doing a lateral, you should stand on the side of the X-ray technician. On the II side, the isodose curves are much better. You can see they're much smaller over here compared to this side. So if I'm doing a lateral like a caudal and I'm marking the interspace, I'm going to try to stand on this side. You see this here. This is, say this is just a fake individual, but you see the X-ray tube, you see the image intensifier. You should not stand over here. You should stand over there. Because only 1 to 2% of the entrance beam exits the patient and hits the image intensifier. If you're a caudal and you're on the side of the X-ray tube, you're going to have exposure that's 10 to 36 times higher. Again, contralateral oblique, this is the worst case scenario. The II is away from you. Your eyes are going to get, and head's going to get a lot of exposure. So if you're doing cases like the minimally invasive lumbar decompression, you should be protecting your head and your eyes. Distance is your best friend. Again, when we're doing bread and butter, there's absolutely no reason for us to be close to the beam. Take steps back. You can make your exposure substantially low. That's why the radiation technologist that's 6 feet away from the beam is getting very little exposure. We heard about collimation. Look at this. If you comb down, you decrease your field of view by 50%. You substantially reduce the amount of scatter radiation. Doubling the beam area doubles the dose of scatter radiation. So you combed here down, you didn't comb down here, and you can see you doubled the radiation exposure. We heard about pulse dose. It's great. You can lower your exposure substantially with pulse dose. You should also benchmark your procedures. There are studies out there looking at the average time it takes someone for radiation to do a procedure. Like if you're doing an interlaminar epidural, the average time published is about 3.7 seconds of fluoroscopy. So, and that's where I got the discography number. It was about 60 seconds published. If you're doing a medial branch block, 5.8. Lumbar transforaminal, 11 to 15. If your numbers are way higher than this, you need to evaluate what you're doing. Shielding, you should be using 0.5 minimum. Thyroid shield is very important. Your thyroid's the most radiosensitive organ. You want to protect it. Lead-lined glasses. Lead-lined gloves are usually about 0.25 millimeters. And again, they're only for scatter radiation. Take care of your lead. Do not fold or bend it. And it should be checked yearly for cracks. So you can see here, even with 0.5 millimeters primary beam transmission, at 125 kVp, still some radiation gets through. We have a shield in our office, and we have lead lining on the base of the bed. So top 10 tips: increase your distance, reduce your time, benchmark your time against published guidelines, use shielding, collimate, monitor your dose. You should be checking your doses at least monthly. Stand on the appropriate side of the machine, keep your hands at shoulder level, position the C-arm with the image intensifier as close to the patient as possible, use pulse or quarter dose, and again, map out the procedure. Fluoroscopy is not free. So you should not be just taking as many pictures as you need. Think about what you're doing. Map it out, how you should be doing it, limit the fluoroscopy. And actually, you know, for half of these things, if you get a great X-ray technician, my X-ray technician's been with me the whole career. I'm very grateful for what she does for me. She maps out a lot of it, and I get very little exposure. So, in conclusion, the long-term risks of low-dose cumulative exposure for radiation are unknown. We are a generation that will have at least 30 years of radiation exposure. We know that non-stochastic effects, that we have to look at the lifetime radiation dose. We know that stochastic effects, they're non-threshold, so your severity increases, or your risk of getting cancer increases the more radiation you use. The International Commission for Radiological Protection clearly knows we need improvements in education and training. This was highlighted in our survey. And you need to understand radiation exposure, technical factors to limit it, procedural factors, patient factors, follow ALERA, and implement strategies for risk reduction. Thank you very much.
I think after listening to this, many people are going to say they're going to quit and change their career. So I think I have a few questions from the audience. And the first question for Dr. D'Souza is, how, when you are learning or ultrasound guided needle injections, what should be the transition from one hand or 1% injection to 2%? Because most of the time people are doing injection in the residency and fellowship and somebody else is injecting. So how do you make that switch, and any tricks for that?
So typically when you're familiar and comfortable with procedure, you could do it yourself. There is extension tubing and other techniques available. You could play with different syringes, and I don't think this is going to be a barrier like for development. We've been using just 1% technique for a long time. It works.
How do you maintain the sterility of the probe when you're doing an injection? I mean, what's your tricks? What's your technique when you're doing injection to keep the probes clean or sterile?
We use sterile sleeve. It's a packaged sterile sleeve, and the person who helps with the with the ultrasound machine, they would handle you the probe with some ultrasound gel. We put the sterile probe, and then we do the procedure. Did I get your question correctly? You're asking if I operate machine myself and do
No,
the
just the injection, and you have the probe and the needle, and now you have an extension and the syringe. So
see, the technology is developing, so I'm not excluding that in the future. We just think about it, it's going to be done. so yeah, but thank you for your questions.
Okay. Do you think for most injection covering the probe with the tegaderm is not good enough, or do you always suggest it has to be a sleeve?
If you're doing just one injection, the tegaderm would do the work. It's I've seen even in our practice physicians using it pretty much routinely. But when you're planning for multiple injections, it's better to use a sleeve. It just kind of you may get distracted. You might. I think it's worth it to invest in safety.
I have a question for Dr. Nagpal. Somebody asked that when you're doing your injection, let's say epidural, and you're injecting the dye, are you injecting dye under live with the pulse frequency or a pulse mode, or are you doing live mode, or what do you do? I mean, so that's what they're wondering.
I think it just depends on the injection that you're doing. I don't do live for every contrast study that I do. So joints for sure not, and like lumbar interlaminars, I actually don't. A cervical interlaminar in the AP view, I'll do a live run, but I think that for a standard thin patient, a pulse live is adequate. So it really depends. If there's hardware also, you may want to do a DSA, which is going to be higher dose radiation. So it's a hard question to answer because it's not specific. There's not a perfect algorithm for that one. I think it really depends on the patient and the injection you're doing.
So when you're trying to localize using your fluoro, like mark the spot, do you have any suggestion how to make sure to use the thing to localize not too big or not too small because of the machine auto brightness? If you put a large metal in the field, is it going to affect the dose of radiation or not?
Sorry, what do you mean? Sorry, if I put a large metal in the field?
Yes, I think maybe Dr. Dave or Dr. Provenzano can help us. The question is, I mean, how does putting a large metal in the middle of the field is going to affect that machine?
Yeah, so I think the first thing I would say is, like, most of our pointing, I mean, one of the nice things now is just using a laser pointer, and we never have to put our hands under the machine. Obviously, if you're using a pointer, sometimes you may have to do it like when you're doing a stimulator trial and you're marking your pedicles. Yeah, anything that you have under the X-ray machine that the X-ray machine views as obstructing the beams reaching the intensifier, then the automatic brightness control will pump out more radiation. That's no doubt. So that's like when if you have lead-lined gloves and it's the machine sees the lead-lined gloves, it thinks it needs to put out more radiation. So a pointer, all those things will increase your exposure because the automatic brightness control is going to adjust based on the fact that it thinks that there's something obstructing the view of radiation and impeding the radiation from hitting the image intensifier.
So from a safety standpoint, do you have any suggestion that what should be an optimal lead covering? I mean, so the question was like cardiologists and I mean interventional radiologists, sometimes they try to use sleeves. So what should be an optimal coverage for a pain physician?
Right. So I think one of the things that was, I'll come back to two things on that. One that was just talked about was talking about like whether you used live fluoroscopy on all cases. I actually agree. Like on interlaminar epidural steroid injections on lumbar spines, you need to be using live fluoroscopy. No, you do not. I mean, I think you have to worry about live fluoroscopy and DSA is when you're really concerned about what the consequences of vascular uptake are and you want to see well. When it comes to like what you should wear for protection, I think that we as interventional pain physicians, fortunately, our procedures are becoming more complex. We're getting exposed to more radiation. I mean, if you're just doing bread and butter medial branch blocks and lumbar epidurals, you can step back and protect yourself substantially. But if you're starting to do more complex cases, then you should protect your head. You should protect your eyes. You should protect your hands. Do I wear sleeves? I don't wear sleeves, but I would not criticize anyone that wanted to wear a sleeve if they were doing like a, you know, for example, like I have a mild case on Friday. You know, when your hand is, unfortunately, your arm, it has to go down under the live fluoroscopy, and it's getting scatter radiation. It's not getting full beam, but you're getting scatter. So if someone wants to wear an arm shield, that's fine. I don't personally do that, but I could see why someone would do that. But your eyes and your head should definitely be protected. And then whatever you use, like for lead, so most people don't wear lead anymore. Like it's just what we talk about lead. But most people wear some type of composite that has similar properties to lead. And you should have an equivalency of about 0.5 millimeters at least, and especially so as minimum. And I saw one question about what you should be. When you look at those new technologies, you should just go to that website and look at the attenuation that composite offers. And if it's equivalent to the lead, then you may be able to use the composite at a much lighter weight.
Do you feel like since the article came out, people have changed, or is it just like human nature, unless there's incentive or penalty, people don't change, so it has to be part of the curriculum of certification that pass the test or you're not going to practice?
Yeah, no, I wish I could say like I published this paper and the world's gotten better, but I know from most research that the average paper that comes out, it takes like 10 years to make a big medical change. So hopefully it will happen quicker than that. But I don't think I think it's highlighted the knowledge of what people really know, but do I think change has occurred yet? No, I think change has occurred at the fellowship level. I think that fellows need to be taught very early on radiation, and I think we should demand education. It's too easy now, in all honesty, to be using a fluoroscopy machine. It's some states you really need minimal to no training. So
one of the things which I feel like we never write our radiation dose in our clinic notes or any notes. And I know that in state of Illinois, I'm not sure, but Joint Commission, they mandate that you have to track dosing for the patient, but not for per procedure. So it's all scattered. So I don't know if that makes a difference, that Joint Commission should insist that each any interventional radiation or procedure that involves radiation should have include in the note the dose given to the patient.
yeah, I mean, I think the dose and the time should be recorded. So we take that we have and it's actually easy to do. You can just, when you save your like images to the PACS machine, you can just have them saved. Most machines give you that data automatically. But the real question is does anyone look at the data? And there's a real question, does anyone change their behavior based on the data? So I think the data is good, but if no one looks at it, then it's not very helpful.
The one question that I missed that was asked some time ago, that if you can explain something about what scatter mean, what is scatter radiation?
Sure. Do you want to explain that? I mean, I can gladly explain it, but if someone else, I don't want to steal the answer all the.
Go ahead. No, it's fine. Go ahead.
Yeah, so I mean, scatter radiation. So like, there's primary beam radiation that comes in, and the X-ray tube shoots out the radiation, and then it goes out to the image intensifier, and it's primary beam radiation. But then there's a bunch of radiation that gets scattered within the patient, or scattered on the bed, or scattered on some of the lead drapes on the bed, and that radiation it was scattered, so it hits the patient, it scatters off them. It's just distortion of the initial primary beam radiation.
I mean, the way I scare people who I talk to, I say there's a reason we can see the photon that started 14 billion years ago. Radiation never dies. They're photons. Doesn't matter how far you stay, they're still going to get you. So you can only run, but they can still find you. So the fewer, the better. I think we're almost at the end of the time. I really appreciate Dr. Nagpal, Dr. Suzo, and Dr. Provenzano for joining us today. It was not easy. They made time for us, and I learned a lot, and I think it was very helpful and useful. And I truly thank you for joining us today. So thank you. So I think that should do it.
I learned a lot listening to the other lectures too. Excellent lectures. Thank you.
Thank you.
Thanks, Mitzi. Thanks.
Bye.
Bye.